Good morning, bonjour. I'm really happy to be here. Thank you to the program committee. I'm going to talk about executive function disorders and how we've managed to engage our clinical team in recognizing disorders a little better and managing them with the patients and their families. Executive function skills are the higher level cognitive skills that we need for independent living, and they include the ability to maintain attention, control our impulses, organize activities, set goals and priorities. Basically, they're how we go about doing anything and whether we do it successfully at all. And over the last decade or so, we've learned that up to 50% of our ALS patients have some level of cognitive dysfunction. And the majority of those deficits are in the areas of executive function skills. And in the clinic, you may not notice these initially because it can be rather subtle. We also are seeing a lot more literature about behavioral and social cognition changes, and those are described as apathy, irritability, disinhibition, self-centeredness, decreased recognition of emotional expression. Now, I think both these behavior and social changes as well as the cognition can affect patients' ability to follow our recommendations. And there's actually some literature that talks about that. I'm going to slander these names totally, but there's a few studies. Elliman in Neurology in 2013, in their study, talked about cognitive impairment in their cohort, particularly executive dysfunction, was associated with a higher attrition rate, and they attributed that to progressive cognitive decline. In 2012, Cho, I'm not sure I'm saying that right, but they said that tolerance to non-invasive ventilation, and they defined that as 4 hours a day, was lower in patients with neurobehavioral dysfunction. And Dr. Olney et al., published in 2005, they found patients with frontal temporal lobe dysfunction, and they grouped executive function disorders and frontal temporal dementia together, had higher rates of non-adherence to feeding tubes and non-invasive ventilation. They further went on to discuss that they found a profound effect of frontal temporal lobe dysfunction on compliance with these patients. They found that people with frontal temporal lobe dysfunction were 2 times as likely to not follow through with a feeding tube or non-invasive ventilation. And I think even though those last 2 studies talk about non-invasive ventilation or frontal temporal lobe dysfunction, or feeding tubes, we can apply those also to just some of the clinical recommendations we make in our multidisciplinary clinics. So how did executive function disorders become an issue for our clinic? Well, I like to think, we're a big clinic in Houston, Texas, led by the Dr. Stanley Appel, and I'd like to think my colleagues are up to date knowing that some of these patients may have cognitive deficits. But I was hearing when they would come back to the charting area after seeing a patient, somebody would say, "Oh, Mr. Smith is non-compliant. He's not using his walker." And, well, I have patients, they don't follow my recommendations either. They don't thicken their liquids. They don't get an augmentative communication device when I think it's time. But I've recognized that this might be due to cognitive deficits. And I've never thought of it as non-compliant, because non-compliant really means outright refusal. And if we know that up to 50% of these patients have cognitive deficits, are they really outright refusing, or is it a cognitive change that's actually preventing them from following our recommendations? So I started talking to the team members about it, trying to make them more aware. Just what can we do to, make a change? In a perfect world, we would screen in clinic, and I know my talk is too long, so I'm not going to go through this because we don't have the opportunity to screen in our clinic. And I know Rod will yank me off the stage. So when you bring up an issue in clinic, as is typical, I was charged with leading the change. So I was asked to determine how can we figure out who has executive function disorders quickly. We're not neuropsychologists. And what are the strategies we can use when we're working with the patients? And how as a team can we better educate the families and caregivers? And that's a tall order for a speech-language therapist. So I engaged in some conversation with our neuropsychologist, Dr. Mario DeLay. So after some conversation, we decided we needed to do a better job in education. So more than just during diagnosis, throughout the entire process of the disease. We also needed to improve our clinical interviewing skills so we could learn some more. And we needed to improve support for the patients with some specific strategies, which we already knew was a problem. This button doesn't work well. Education-wise. We need to educate from diagnosis, which we do. I know a lot of folks don't have neuropsychologists. We do assess at diagnosis, but the patients are overwhelmed by all the information they receive. So they might hear that the patient might have cognitive changes, but they might forget that. So we've counseled all the team members, and everybody realizes that they need to be on top of things. And so if they hear something like, at least my mind's intact, they know to gently remind them that, perhaps there'll be cognitive changes, or there might be some changes in thinking. Or if they hear the patient's family members say, he's starting to interrupt a lot, to recognize that that might be a signal that there's some cognitive change. And so other things they might notice are the patient even saying, I'm not participating in conference calls as much as I used to. And that could also be a signal of some cognitive change. And they suggest to the patient, there may be some changes in your thinking, and bring that up to the neurologist. So we've also provided some resources for them that are written out handouts that describe executive function disorders and behavioral disorders, and those are available for any clinic member to hand out. I'm going to talk a little bit more about those. The interview technique we introduced is called motivational interviewing. It was developed in the 80s. It was first used with alcoholics to get them to stop drinking. It's been pretty successfully used in multiple areas of healthcare, as well as law enforcement and other fields, education, things like that. It includes some techniques that address ambivalence and resistance when you're trying to work with patients that are needing to change their behaviors. And those techniques can also be used when dealing with the apathy and initiation issues some of our patients have. And I can't teach us all how to do motivational interviewing in less than 15 minutes, but we're trying to use some of the techniques in clinic when we're working with the patients. So 3 of the basic skills are open-ended questions, empathy and listening, and empowering the patient. Now, I know most of you are sitting there saying, I already do this. I don't need to learn how to do this, motivational interviewing. I thought I did it too, and then I started listening to myself. So open-ended questions allow the patient to talk some more. Some examples are, what concerns you about wearing a non-invasive ventilation mask? What needs to happen for you to consider a feeding tube? I found that I was being kind of directive. I was asking yes, no questions. Are you thickening your liquids? Did you get a communication device? That puts patients on the defensive. When my mother does that, I back off. I'm not talking anymore. So the open-ended questions engage the patient more as a partner, and they talk a little bit more. I think we're all empathetic listeners. We're in healthcare, we're professionals, but motivational interviewing introduces the idea of reflective statements, which are a summary of everything the patient has said. So the question might be, what concerns you about wearing your mask? And the patient may respond, I'm concerned, no one can hear me at night. And the reflective statement may be, I understand you're worried no one can hear you call out for help at night. And that may allow the patient to expound more on their fear. They can problem solve. And you've already gone farther than if you just say, are you wearing your mask? Are you using non-invasive ventilation? You've gone further already. We all want to empower our patients, and motivational interviewing is all about that. But we do a lot of teaching instead, We tell them, you do this, and they listen, do this, listen. They suggest asking permission before giving information. So, may I tell you a little bit about voice banking? What do you know about feeding tubes? May I tell you something about that? If you want to probe a little bit about executive function disorders, a couple of ideas. You can ask about favorite activities or what makes the patient angry to probe for initiation or motivation. A patient who has a lack of initiation probably is not going to have strong feelings about anything. Planning or organization, if you want to probe in that, you can ask them about holiday plans, what they're going to do after they leave the hospital, how they're going to get there, how they're going to execute it. If they have poor planning or organizational skills, they're not going to generate appropriate plans. My occupational therapy friends like a motoric skill, and so you can copy a series of letters and script. That's my handwriting. If you have trouble with organization, that's going to drop off. You're going to forget what you're doing. When you're working with the patients with executive function deficits, having structure is perhaps the most primary thing you need to talk to the families about. And we now talk to the families about having a daily schedule right off the bat, especially if they already know their executive function deficits. That can include, a daily checkoff list of what to do, like activities of daily living, meals, reading the newspaper together. And clinicians, we can throw in our goals. I can have speech intelligibility strategies while you read the newspaper together. You can, do your breathing exercises for 15 minutes at some point. It's important to consider when the patient's functioning best, because if they're tired, they're not going to do well. They're going to need more time to accomplish things, especially if they're using strategies. Strategies go out the window if they're time constraints. It's also important to pair something pleasant with the activity. Working on eye gaze or practicing with your augmentative communication device, if you're writing a letter to a daughter or something like that, it's going to be more meaningful than just practicing writing words or finding a page. And finding activities with no expectations. The quickest way to ruin a relationship is to always be doing something with an expectation that can't be met. And finally, creating a system within that structure. My patients don't use those communication devices. They're gathering dust. So pulling it out always at the same time, using it for 30 minutes. Walkers, canes, other things can be left all over the house, but always having it in the same place, by the chair they always sit in. So they, pick it up, they see it, it's a routine. They don't have to remember, it's there. It becomes a habit. Pills, medications can become an issue, so a pill organizer can help. You could use prompt cards, cue cards, if there's swallowing strategies that can be left on the table. Rehearsal and routine are always important. I tell my patients, families, and caregivers, you need to be the frontal lobes. The patients aren't going to initiate. You're going to have to pull out the device. You're going to have to start the exercises for them. Also, give patients the benefit of the doubt. They don't like the changes either. They don't want to use these devices. Hearing, oops, you forgot your cane, I'll go get it, is better than, you forgot your cane again, you need to use it, you're going to fall. That type of approach is going to be better than hearing something like that. Also, it's important to not take things personally. We've all heard, he doesn't do anything. He just sits there. He doesn't try. The brain is changing. The patient can't fix things by trying harder. And more importantly, the caregiver can't change things by trying harder either. You can't take it personally. In conclusion, it's important to remember that patients with ALS may have executive function disorders, which cause progressive cognitive decline throughout the disease. Executive function disorders may be the reason patients are not adhering to our recommendations. It's important to have some interviewing techniques to learn a little bit more about the patients. And executive function disorders, the patients with those need some structure in the system throughout the disease. And education and support is always needed. I think working with these patients with cognitive disorders is one of our biggest challenges, because they can really lose out on some of the benefits a multidisciplinary clinic can offer. And thank you to Dr. DeLay, our neuropsychologist, for his resources. And thank you.
Thank you, Laurie.